Welcome to the Royal College of Physicians Edinburgh Clinical Conversations podcast. Each episode within this podcast series, we delve into a different medical topic with an expert speaker to join us. If you want to find more about the Royal College, then please do head over to the RCPE website and have a look at the education stream and see if membership would work for you. It offers a host of educational updates and activities such as the evening medical update, the Royal College Symposia, and many more. Please don't forget, if you listen to our podcast, to give us a rating on one of the podcast platforms or subscribe so that it can come directly into your podcast stream.
So hi, and welcome to this episode of Clinical Conversations brought to you by the Royal College of Physicians of Edinburgh Trainee and Members Committee. My name's Kat Ralston. I'm a member of the TNMC and a Geriatric Medicine Registrar in Edinburgh. I'm delighted to be joined today by Dr Imogen Smith to chat about palliative care in hospital inpatients. Imogen is a consultant physician and geriatrician in NHS Lothian. Thanks so much for joining us. I thought it might be useful for you just to tell us a bit about your context and your interest in palliative care.
Sure. Okay. So thanks for having me on the podcast. I'm a consultant physician and geriatrician, as you say, but I've got a special interest in end-of-life care. And I look after mostly older adults, but some younger adults as well at the end of their lives in a variety of contexts. So sort of most significantly in terms of the palliative care that I do, I work at a community hospital in West Lothian called Tippett Hill Hospital. And we have 24 beds there, which is predominantly providing end-of-life care for a variety of different patients. I'm a jobbing geriatrician in a district general, busy district general, and I do the acute medical take as well. So I'm sure most of your listeners will be familiar that there's a lot of dying that happens in hospitals, in general hospitals, both on geriatric wards and, even in the kind of medical assessment unit. So I also, see patients there. And finally, I work as the consultant at Hospital at Home in West Lothian, and we see patients in their own homes. And whilst we're not the specialist palliative care team, and certainly we get the specialist palliative care team involved if we need to, we see a lot of end-of-life care in that context as well.
So lots of experience in lots of different aspects of palliative care. So I think this should be a really good podcast. So you've covered this a little bit, Imogen, but I guess I'm interested in why we think this is an important topic for our listeners.
I think death is relevant for most specialties. So obviously, I would imagine that most of your listeners might be from a physicianly background, although I'm hoping that there might be some other people as well. But if one works in a hospital or in general practice, that is where actually the majority of dying people are. So, I won't kind of flood the podcast with statistics, but I think it is useful sometimes to think about where people die. People who died in Scotland in 2022 to 23, 45% died in hospital, 30% died at home, and 19% died in care homes, and less than 5% died in a hospice or a specialist palliative care unit. So whilst I think we think of specialist palliative care as being the absolute experts in death, most death is happening in other places and other contexts. So I think it's important for everybody. Palliative care, as I said, don't get involved with everybody. So I think it's really important that trainees and junior doctors on the wards have a good grounding in basic end-of-life care where it's not maybe particularly complex, but where there are symptoms that can be, need to be controlled. And so hopefully we'll cover a bit of top tips for those kind of situations as we talk.
You've convinced me. I mean, I'm already convinced, Imogen. And I think there's real parallels when I heard you speak that it's like frailty is everyone's business and geriatricians can't look after everyone with frailty. And I think that feels very similar to palliative care. It's everyone's business.
Absolutely. I think it's the bread and butter of what medical doctors do, actually. And I would hope to convince you all that you are all capable of starting a syringe driver if that's what the patient needs.
That's our learning outcome by the end of the podcast. Great. So we're going to have a little bit of a slant on older people when we're talking, so we're both geriatricians. So it might be good just to think about what's different about the older adult when we're thinking about palliative care.
Absolutely. So I think there's probably 2 or 3 differences. As I said, there are 45% of people in Scotland die in hospital, 30% at home, 19% in care homes. But for the over 70s, that's 27% in care homes. So I don't think that would be a surprise, particularly to anybody. And certainly anybody who's set foot in a care home can see that lots of palliative care happens in that context. and particularly in older adults. And the conditions differ as well. So there is more dementia in the deaths that happen in care homes, much more dementia. More people with cancer die at home, and we can go on to talk about why that might be. And hospice deaths, so that's a small proportion that die in a hospice, are overwhelmingly dying of malignancy. So 86% of hospice deaths are cancer related. So I think already we can see that depending on your patient, depending on their condition, and depending on their age as being part of it, their place of death is going to be different and the conditions may be different. And the third thing, apart from age and condition, I'd say that kind of influences place of death is deprivation. So the most recent Scottish data shows that in the least deprived populations, there are many more care home deaths, so up to 25%, whereas in the most deprived communities, only 14% are dying in care homes. So, I mean, that might be for a variety of reasons. It's potentially due to family support, it's potentially due to age at death. It might be down to lots of things. It might be down to where families are and whether they're spread out and unable to care for people at the end of life. So those are the kind of key differences, I think, that we see in older adults. And then as part of that, and the kind of underlying difference there is about predictability. So I think one of the key differences between older people and younger adults dying of malignancy, for example, would be the predictability in knowing when that death is going to occur or when end-of-life care needs to happen, and people's function throughout that. And I'm sure lots of your listeners will have been in a situation where they may have thought an elderly patient was going to die of a non-malignant condition, and then they've rallied and actually, survived to discharge, but potentially very much frailer. And so you've got this much longer prodrome at the end of life where things are difficult, things are unpredictable. You might not be surprised that that person would die at any point, but equally they might go on for another 6 months. And that can make it really difficult to plan palliative care. Families can kind of pull out all the stops for somebody who is going to die in 6 weeks' time. They can give up their work for a few weeks. They can take a rota of children to stay with mum, potentially, if she's going to kind of predictably die of cancer. But those patients who are grumbling along with dementia or frailty, they may kind of fall off their perch at any time and have a condition which is not going to be reversible. We may have already all agreed that there is no more active treatment to be given and no more antibiotics for that next chest infection. But then that patient goes on and surprises us and lives for another several months. And people find it very hard to put life on hold for that unpredictable length of time. So I think those are the sort of broad brushstrokes of what is different in elderly care.
Yeah, I think that unpredictability and uncertainty can be really challenging, and we'll get on to the communication about that a bit later on. You mentioned a little bit about trajectories, and I always have these graphs in my mind in which the listeners may or may not be familiar with, and we'll put a link in the show notes about them. But I think this thing about trajectory and identifying deterioration and dying can be really tricky, and I would just be interested to hear your thoughts around how you approach that.
Yeah, so you mentioned a graph, and I've got a pretty well-known graph in my head at all times when I think about prognosis, actually. And it kind of changed my practice a little bit when I started talking to families about this as well. And I've had several families have a realization moment where I've kind of explained things in this way and they've gone, oh, now we get it. So the graph I'm talking about is, I think, probably published by a variety of different people, but certainly published by Lunny et al. In the Journal of American Geriatric Society back in 2002. And essentially there's 4 different trajectories on this graph. So on the x-axis, there's time, and on the y-axis, there's function. And geriatricians like talking about function, as you know, Kat. So, some people die suddenly. So you get hit by a bus, you have a big MI and you die. And palliative care are not involved in those patients. There are then the patients with cancer, and people can live with cancer well for a very long time now. So people with breast cancer, for example, can live for many, many years, having treatment, having a break from treatment, having some more treatment. They might be working, they might be very well during that time. But when they start to decline, once they're on that slope, it's relatively predictable. And obviously oncologists have great data and can often accurately predict prognosis, pretty well. And very much more aggressive cancers are the same. So once you're on the slope, the decline might be over, a matter of days or weeks. But once you're on that kind of slope of decline, things are not going to reverse. And then we think about different pathologies such as organ failure. So I would include cardiac failure, COPD, liver failure to a certain degree, or maybe less predictably. And you have this sort of dip in function and they maybe get hospitalized with an exacerbation and then they recover with treatment, but they never quite get to their baseline function again. But they might poodle along for another few weeks or months until the next exacerbation. And those exacerbations get more severe and closer together, and function doesn't recover to the same degree in between. And maybe the package of care is put in at some point, and then maybe that person stops being able to do certain things for themselves, but they recover after an exacerbation. And those patients are really difficult to plan for because it can look in that midst of that exacerbation like they are sick enough to die. So that's one of the phrases that I think is very useful to talk to families. And in the middle of the night, as the medical registrar, you're absolutely right to call that family in to say, your mum is sick enough to die. I'm very worried about her. This exacerbation of her COPD is really dreadful and she might not recover. But in the morning, after you've given her the NIV, I'm sure you've been in this situation, Kat, and you think, oh my goodness, she's eating a porridge. I can't believe that. And the family go, wow, it's a miracle. This is great. But on the 4th, 5th, 6th exacerbation that year, and you're saying, I think your mum is sick enough to die. I'm really worried about her. That family have heard that before. And that's where you get these phrases, she's a fighter. We've seen this before. I think she'll pull through, doc. And you think, oh, I'm not getting through to them. And you're not wrong to tell them that in the middle of the night. I think that is the right approach. But we also know that doctors overestimate death at that point. So they underestimate prognosis, I guess. So they overestimate those patients that are going to die. Lots of them recover, but they're not going to recover every time. But you don't know which exacerbation is going to be the exacerbation. So planning for those patients is really difficult because if they're benefiting from treatment and benefiting from coming into the acute hospital, you might not want to let them stay at home the next time. But that patient might be telling you at the same time that their preferred place of death is home. Well, if it's not going to work, I want to stay at home. And of course, we don't know which one's going to work and which one's not going to work. So that can be a real challenge. And then finally, just coming back to our graphs, we've got our frail patients or our patients with dementia. And there's this sort of wiggly line with a really poor function actually and being very dependent on care. But it just wiggles up and down a little bit and sort of slowly slopes downwards as people deteriorate. And at any time along that line, one would not be surprised. So this is often a question asked of GPs. Would you be surprised that this person was to die in the next 3 months or the next 6 months? And that answer would be, no, I wouldn't be surprised. But equally, they might have 2 or 3 years at a care home with quite severe dementia, for example.
Yeah, I think that's a really nice explanation of a graph over audio, which is good. And I hope the listeners have a look at that if they haven't seen it. I find it really helpful too.
I would say one more thing is that you can be on more than one curve. So some of my patients in the community hospital have 2 or 3 different conditions, and they might have a cancer, for example, a lung cancer, but also COPD, maybe a bit of mild cognitive impairment that's got worse since an admission. And actually, sometimes what I have to do is try and work out which of these lines is the predominant one, which of these lines is the one that is going to cause this person to die when I'm thinking about prognosis, both for care planning, but also for discussions with families and patients.
Yeah, absolutely. Often there's more than one thing going on, isn't there? And I guess that brings us on nicely to, we've talked a little bit about it's really difficult to predict which illness is going to be the illness that they're not going to recover from. And when you're at the front door seeing people, that can be particularly challenging. And almost invariably, at most handovers, I hear a story of someone who might be frail, unwell with a pneumonia, they're getting tazocin, fluids or whatever. And if you dig down a little bit deeper, they're maybe a bit agitated, they're breathless. But because we're giving them active treatment, we feel like we cannot give them symptomatic treatment. And I can't tell you how many times I've said we can do both. And that is okay, as long as we're communicating that properly, and we can absolutely attend to symptoms while we're actively treating someone. So this concept of parallel planning, I think, is really important.
Yeah, absolutely. I would really agree. So I think, we talked certainly in Lothian about treatment escalation plans, but this idea is a kind of universal idea now about trying to plan the care when someone comes into hospital that they would benefit from and that they wouldn't benefit from. So at the front door, that might be this person clearly wouldn't benefit from an attempt on CPR, and so they have a do not resuscitate kind of form put in, but that they might benefit from, for example, NIV. We've talked about a little bit with COPD, but they wouldn't be a candidate for level 3 intensive care, for example. So we're all kind of familiar with that idea. I think what I see a lot of is this active versus not active treatment. So this active or palliative. And we know from studies in cancer care that people live longer actually if you give them good palliative care early. So in oncology, there's really good data, robust data that says that palliative care alongside ongoing active cancer therapy is good for patients. It's the same in the acute medical unit. So it's the same with that patient who is frail but is on antibiotics, and we're going to give them 24 to 48 hours to work, and we're going to see what the trajectory of that patient's condition is. But they can definitely benefit from some morphine or some midazolam to deal with their symptoms. And you are not going to hasten that person's death. You are not going to undo the good that you're doing from the fluids and the antibiotics. You are going to make that patient comfortable, and you're going to make sure that their family are not distressed while sitting at bedside of their loved one, seeing distress and thinking, well, I've got to choose. I've got to say, please stop now, and then she can be comfortable. I would really urge you to get away from this idea that we, quote, palliate patients. We don't actively palliate patients. We look after patients and we address their symptoms alongside actively trying to reverse any pathology that we can.
Yeah, totally agree. So, reversing the reversible, but also making sure that someone is comfortable and has symptoms controlled makes absolute sense to me. And that's really interesting that has good oncology data for survival and morbidity as well. And I guess that brings us a little bit on to the communication around unwell patients and patients that we might think are dying, and how we communicate that to patients and relatives. Obviously, that's quite a big topic, but maybe just thinking a little bit about what approach you find helpful to try and have these conversations.
Yeah, so I think there are certain phrases, aren't there, that you kind of fall into and get to use as you develop your particular style or your particular style of communicating. And there are certain phrases that I use. I think everybody knows what palliative care is. And so I actually quite often say palliative care. We will give palliative care. That can bring its own problems because sometimes people see that as either not doing anything else or it doesn't leave that nuance of unpredictability and people rallying, and particularly older people when we're thinking about people rallying from infections and things. So use that phrase with caution sometimes. My other approach is always be honest. So if you don't know, say, I don't know. I always leave room for me being wrong because I've been wrong before. And I think whilst I would, come back to that 2 a.m. in A&E looking dreadful exacerbation of COPD, you might have to hammer the message home somewhat to a shocked family. Always leave room that things might not go as you're saying, because I think that builds trust. And I think that means that they don't think, well, this doctor doesn't know what they're doing because something different happened. Okay. So yeah, I think honesty is the best approach. The final point on communication I might say is particularly with patients, sometimes leave room for more optimism than I might with their family, depending, and I would take my lead from the patient. Patients need to have hope. So I would ask the patient what they want to know. And some people do not want to know about prognosis. And so I would not be enforcing or hammering home messages about prognosis to patients necessarily if they don't want to know. I think you have to take your lead from your patient. If the patient asks, I will absolutely answer that question honestly and to the best of my ability. And the final thing I'd say is sometimes I say, I don't know, I can't answer that question today because I've just met you, but I'm not avoiding the question. Could we see how things go over the next week or so? And I'm going to have another conversation with you about this next week. And that's one of the things I absolutely love about my job is the continuity of care that I get in my community hospital. And I know that I am going to be the person that sees them next week. And I realise that in acute hospitals, that's very much more difficult.
Yeah, that feels like a privilege as opposed to something that happens all the time, which makes it really difficult. Thanks. That's really helpful. And I went to an interesting talk today thinking about, we talk a lot about what matters to people, and that's really important. And I think that is really important. But the question that we ask can bring different results. So I think if you ask people what matters to them, you don't get a good response often. To live longer or to, be up something very short. And actually what I've been hearing recently is things like, well, what does a good life look like to you? What does a good outcome look like to you? What would be bad? What does an unacceptable outcome look like to you? And that's brought some really nuanced and useful information when you're guiding these conversations around future care planning. And I just thought that was really interesting to think actually how we phrase what matters to you conversations, what brings you joy, what would actually not be acceptable can really help.
Absolutely. I would completely agree. And I would say there needs to be follow-up questions depending on what comes out. And certain patients will interpret that in different ways. And I think you just need to be open to the fact that people might say very different things, and that's to kind of be guided by them, I think.
Yeah, and I think that's the whole thing, isn't it? That this is shared decision making and we're being guided by the patients and the relatives. And we have all the medical experience, but they've got their life experience. So it's about coming together with that, which I think is important. I think it's important to think about location of care, because once someone's in hospital, often that feels like the default, doesn't it? That person, if they're very unwell, if we think they're dying, they're probably going to die in hospital. And I guess it's just thinking about other options are available, and we need to think about that and communicate that actively.
Absolutely. So this will very much depend on your kind of local setup. So I'll try and talk in general terms, but certainly where I work, one of the reasons that we have a community hospital where I do a lot of palliative care is that we don't have a hospice in West Lothian. And whilst West Lothian patients sort of come under the remit of the 2 Edinburgh hospitals that are run by charities, that's 20 miles away on the M8 through the bypass, through busy traffic. And patients just do not want to spend the last days of their loved one's life commuting for an hour and a half to see them in a hospice. So for that reason, most West Lothian patients do not ever have access to a hospice. We do have a pilot of hospice at home at the moment, but it's very small numbers and funding is extremely uncertain, I think, going forward. And so we come back to most death not happening in that specialist palliative care environment, actually. So I think where the palliative care specialists are superb is in knowing how to get people out of hospital if possible. But again, we come back to that predictability, and I think that's frankly much easier in younger patients. So, a patient in their maybe 50s, 60s may have grown-up children who can all kind of pull out all the stops and have a rota of overnight care at home, and can juggle that, and families do amazing things all the time. As patients get older, in my experience, that becomes much less likely. So there's both that predictability of we can't do this forever, and actually we don't know when this person's going to die, and it might be in 3 months' time, and we can't put life on hold for that long. There's, people in their 90s, their children are in their 60s, and they've got grandchildren that they're responsible for looking after, and they can't stay up all night with mum if she's distressed. So there are life circumstances which I think shift as the patients get older. And then I'm going to say something maybe a little controversial, and certainly I don't have data to back it up, but I think in my experience, the sex of the people who are dying matters. So when the family has lots of women in it, that tends to be when care can happen. Actually, we know that caring responsibilities fall on women proportionately. That's just the way it is. So I think if I have a patient with, 6 daughters and 3 nieces, you kind of suddenly think, okay, this might be possible. The other things that might be helpful in getting people home are provision of a hospital bed. That can be tricky, that can be difficult to do at short notice. Care provision, so packages of care, waiting for new packages of care is very difficult, all across the country. And overnight care tends to be the limiting factor. So I think if people need overnight care, that can be really difficult to get people home to die. And that might be when they either need to stay in the acute hospital, or if you're fortunate and have access to palliative care beds in a community hospital, then that could be one of the deciding factors.
Yeah, so we can think about other places, but I think that communication of uncertainty and that things might be longer than, the few days that the family are thinking in their heads before you have that conversation is really important. As an aside, you often have the conversation about, well, we need to make a judgment call on the day whether they're going to be fit enough to transfer to home or to a community hospital. And that can be tricky too.
Yeah, and I think, again, knowing is this the right thing to do, is this the right thing to move them, is really difficult. I have got that wrong quite recently. I think honest communication, again, with the families is important. How important is it to them that this person moves to potentially get a side room, have space and time for the family to have that special time, versus how devastating would it be if they died in the ambulance? And some patients will tell me that actually, dying in the ambulance is not the worst thing that could happen, and that it's worth the risk. And some people obviously would say that was completely unacceptable. So I think you have to be, as honest as you can, and again, take your lead from the families. I think if somebody was unconscious, I would probably say that was too late for them to move, and the benefit of them moving is probably not there anymore. But that can be a difficult call, and it doesn't feel good when you get it wrong.
Yeah, I think, again, that just comes down to the fact that we can't be right all the time. It's not possible. And it's how you communicate the uncertainty and risk, and that is what's going to help when the situations invariably happen.
Absolutely. I think if you explain to families that that is the risk and that's what we have to make a decision about, families are very understanding that we are people too, and that we are using our judgment and that there is no blood test to tell me when that person is going to die.
Yeah, really important. Okay, so I think we might talk a little bit about symptoms. We can't talk about all symptoms within this podcast, but maybe we'll just pick one and just think about your approach to it, because that might be quite helpful to the listeners. So could we maybe think a bit about pain, Imogen? What's your kind of approach to that in the palliative care setting?
Yeah, so I think pain is one of the symptoms that everybody kind of is familiar with, and we deal with pain in a lot of different situations. The first things I would say is, this is an evidence light area. So all patients are different. Geriatric patients or frail patients don't get in studies and don't get in trials, as we know. And I think we have to accept that everybody's metabolism is different, and what works for one patient might not work for another patient. So with that in mind, I have a kind of approach to pain in the sort of dying patient, or the patient I think is approaching the end of life. And that would be paracetamol. Okay, so paracetamol can be very useful for people. And then I would probably go straight to the kind of step 3 on the WHO pain ladder. There is increasing evidence that missing out step 2 is actually not detrimental and actually beneficial. You get better pain control quicker if you go to step 3. We also know that lots of those step 2 drugs like NSAIDs or codeine or tramadol or nefapam are really tricky and pretty contraindicated in most of our frail elderly patients. They have high anticholinergic burden. They cause delirium. I would hope that most geriatricians are kind of relatively comfortable with going to strong opioids and actually recognizing that that is probably a better approach. And so my approach would be start with number 1, go to number 2, and then worry about third and fourth line after that. And by number 1, I would say morphine, and number 2, I would say oxycodone. And there may be a good reason to skip number 1, morphine, if that person has, for example, renal impairment. But I don't think there is good evidence that oxycodone is better in the frail elderly. There's this kind of suggestion for a few years that that was potentially less deliriogenic. I really don't think that that evidence is strong. And the downsides of going straight for oxycodone, for example, you think, okay, this patient's frail, they're at risk of delirium, I'm going to give them oxycodone because I've heard that's better. And then you don't see that patient again, and they might get problems with that, or it doesn't work, or they get toxicity. And the next person comes along and we're already on second line treatment, and we're thinking about third line treatment, and that third line treatment might be much more difficult practically to give. We might be thinking about alfentanil syringe drivers, for example. And morphine is that great drug for that patient, and it might be the perfect drug for that patient, and nobody knows that we haven't tried it yet. So my argument would be, if everybody had a sort of systematic approach, that you start with morphine as long as there's no strong contraindication, and renal impairment would be one, but if their renal function is good, then you start with morphine. We can sometimes jump to conclusions that the new painkiller must be the cause of delirium. And actually, we know that there are myriad reasons for delirium. So I would look for those other reasons. I would look for urinary retention. I would look for constipation. I wouldn't jump to the conclusion that it's definitely the opioids. There's good evidence that undertreated pain also causes delirium. So I would be very keen to kind of emphasize that I think elderly patients do get undertreated for pain a lot. They're not as good at reporting pain. They're not as good at using 1 to 10 scales for pain, for example. They will cluster around either 5 or 10, and there's that less nuance. And so we have to bear that in mind, that we don't want to undertreat our patients. So I would start with morphine. If morphine was ineffective, I might increase the dose. And I would want to be looking for a good response. So that would be subjective and objective. I want the nurses to tell me whether they think that patient is comfortable. I would like the family to tell me if they think that things are better, as well as whatever the patient can tell me. And I might increase that dose until either things just are not improving, or we might start to get toxicity. So the things to think about in opiate toxicity, or opioid toxicity, I should say, is delirium would be one, hallucinations, fleeting hallucinations in the periphery of the vision that then disappear, vivid dreams, nightmares. And I would always ask the patient about these things, because they won't tell you unless you ask. And if a patient is in pain, but also toxic, that's really a good indication to switch to a different painkiller, so a different opioid. So I might try oxycodone. And the good thing about morphine and oxycodone is that they come in modified release tablets. You can give them twice a day. They're pretty small tablets. They're easy to take. And you would use breakthrough medicine to top up, so an immediate release dose during the day to top up. And again, if you're in a hospital, you really want the nurses to be offering that, to be asking about pain, and to be looking for those non-verbal cues of grimacing or looking uncomfortable, as well as asking your patient, who may deny pain but may still be in pain, particularly if they've got cognitive impairment. I would also urge people to make sure that their calculations are right. So we talk about using a sixth of the total dose as a breakthrough, and it doesn't have to be exactly a sixth, sometimes a sixth to a tenth. But if you are increasing your long-acting medicine during the day, then you need to be also increasing the PRN dose that we use as required. So I think if you're struggling with oxycodone and someone is toxic on oxycodone, then the next steps would, in a hospital setting, certainly my kind of next go-to would be an alfentanil syringe driver. So alfentanil is really great in renal impairment, so you can use it with really quite low eGFRs, and it's quick in and quick out. So if you give a dose, then it will not hang around, it will be dealt with by the body quite quickly. That can be a good thing, but it can also be a bad thing. So it means that their top-up dose won't last very long. And it means that we have to give it in a syringe driver is the way of giving alfentanil. So they have a 24-hour pump of alfentanil, and then they would have top-ups on top of that. With alfentanil, I would also encourage you to think about giving another opioid alongside alfentanil as the breakthrough. So maybe low-dose oxycodone if they've been toxic with other drugs before. You might reduce the dose of the oxycodone that they were having. And it means that the nurses can give something that will hang around a little bit longer as a top-up. And hopefully, because they're not now on that kind of long-acting oxycodone, they've got less of it in their system and the alfentanil is working well in the background. That small dose of oxycodone can often be really well tolerated.
That's really helpful. Thanks so much. The morphine versus oxycodone thing always comes up, doesn't it? And I think the other point is certainly where we work that oxycodone requires 2 nurses to check it. And therefore, when your patient needs pain relief at 2 a.m. and there's 1 nurse on the ward, then that can lead to quite significant delays. So yeah, if there's not another problem with giving morphine, then...
Absolutely. And I think some of this sort of perception potentially comes from places where they've got very protocolized approaches, and that can be really beneficial. If you've got lots of people, for example, on orthopedic wards, for example, you've got lots of frail elderly people, many of whom will have renal impairment, and you want a protocol that fairly junior members of staff can activate in the middle of the night when they've got 6 people with hip fractures to clock in, then by all means, I absolutely accept that there is good reason for that drug being oxycodone rather than morphine, because you're trying to treat the biggest number of people with the most appropriate drug. But if you're taking a patient-centered approach at the end of life, I would urge you to think about starting with morphine, moving to oxycodone, and then obviously getting specialist help or senior help with more unusual drugs like alfentanil if you need to.
And when would you sort of think about adding in any adjuncts like, say, sort of neuropathic agents?
Yeah, so I think, again, we kind of got this perception, certainly as geriatricians, that these drugs like amitriptyline or pregabalin or gabapentin, bad in the elderly, right? They've got anticholinergic burden and they cause falls, and we spend our lives stopping amitriptyline in the patient that's come in. I think it all depends on context. So if you've got somebody who's in a 24-hour care setting, like a community hospital, for example, or even is going home but is going to be cared for in bed with carers coming in multiple times a day and then no longer mobile, then I think that falls risk kind of falls away, and actually symptom control is very much more important. And so in those circumstances, I would consider adjuncts or neuropathic agents in the elderly if there was good reason to, and start low and go slow would be my approach, like I'm sure all geriatricians have told you, Kat, before.
Yeah, the classic. Very important, start low and go slow. And I'm just going to reference here that we'll put it in the show notes, but the Scottish Palliative Care guidelines have really helpful choosing and switching opioid guidance, which will give you detail on dose switching and breakthrough doses and lots of very, very helpful advice.
Absolutely. And my tip there is get yourself a piece of paper, a pen, and a quiet room that you're not going to be disturbed, and shut the door and write out those numbers. And I still do that. If I'm doing more complicated switches, nobody's expecting you to pluck these numbers from your head, but the guidance is there in the Scottish Palliative Care guidelines, which are really excellent.
And if there's another person there to check them with you, then that is really helpful as well.
Absolutely.
Okay, so I'm going to move on to, we've sort of touched on syringe drivers there, or continuous subcut infusions, CSCIs, and I think that is something that can feel a bit tricky if you're the doctor on in the middle of the night or on call, and I thought it might be helpful just to talk through an approach to syringe drivers in these patients. So maybe let's just start with, when should that be coming into our heads?
Yeah, so I think there are a couple of different reasons for starting syringe drivers. The first kind of obvious one, I guess, is if people are unable to take oral medicines, then that is when you're starting to think about using subcut medicines. If they've already needed some breakthroughs, for example, of PRN subcut medicines like morphine or midazolam, it's clear that the oral route is not going to be sufficient for their long-acting opiate that they may have already been on, or you may have started recently. And so that would be a good indication for needing to change to a syringe driver. The second reason would be if there is some problem with the efficacy, I guess, of the oral route. So potentially they're still able to swallow the tablets, but they're just not being effective. And that might be if you've got, for example, bowel obstruction or various bowel problems. But it might be because you want to give a drug that can only be given subcut. So midazolam is a drug that's very commonly used at the end of life, and it is only given as a subcut medication in palliative care. So, your patient might have had a benefit from lorazepam, for example, or PRN diazepam, but that they really are starting to become anxious or distressed and need that continuous infusion. And that would also be a good indication for maybe thinking about switching the opiate into the pump as well.
Yeah, that's really helpful. And so really, oral route not available, not absorbing meds that we can't give orally, or someone's needing doses of as required medication for symptom control, and we predict that they're going to need ongoing doses. And so when we're thinking about starting a syringe driver, people can get a little bit tied up in knots about sort of starting doses and how you work that out. Tell us about that.
Okay, so the first thing I would say is starting a syringe driver is doable, okay? So it's not this scary thing. And most trainees will have somebody on the end of a phone that they can ask, check, run things by, but they might want to make that decision. And I would urge you to look at your patient and think, is this the right time? If they've used, for example, some of their PRN medication already, so let's take an example, that frail elderly patient who's come in, they've had a really severe infection, let's say a chest infection, and they've had some antibiotics and they've had some fluids, but it has not worked, and it's clear that that person is coming to the end of their life, they are dying. And they may look distressed, and you're asked to see them in the middle of the night. And let's say that somebody proactive and sensible has already started those ACP medications, those just-in-case medications, when they came in, all right? And that we were talking about that parallel planning kind of concept. And they've not had any. And you see the patient, and maybe you've made the decision to stop the antibiotics, maybe you haven't, maybe that decision needs to be made right now. Maybe that's not the most important decision to make right now, but you see that your patient is distressed. Ask the nurse to give a dose. Okay, so ask the nurse to give a dose of morphine, a dose of midazolam, whatever you think they need, and come back and see what effect that had half an hour later. All right. And that will give you such a good starting point for knowing what needs to be done next. Okay, so if that 2 milligrams of midazolam or 2 milligrams of morphine really settled that patient, who is maybe 50 kilos, has been failing in a nursing home for some time, and they are opiate naive, and that settles them beautifully, then that's all that needs to be done. And you can review that again in the morning, and you might tot up what they've had, and you say, well, they've had a couple of doses, but I think they're really settled. And you might persist in that manner. If actually it required 2 or 3 doses to get that person settled within a reasonably quick succession, so maybe between the hours of 2 a.m. and 5 a.m., they ended up needing on the hour medicines, that's when to think about starting a syringe driver, because it's clear that maybe they're starting to become settled with those kind of cumulative doses. But if you kind of extrapolate that, it's clear that they're going to need kind of more over that 24-hour period. And I would argue that in a frail elderly person who's opiate naive, whose maybe last bloods showed normal renal function, you are not going to do any harm by starting 10 milligrams of morphine, 10 milligrams of midazolam. And that is likely to keep them pretty settled. They can have top-ups as they need them, PRNs as they need them. And you would hope that then somebody would review them at the next ward round or the next working day. You might then have access to a palliative care nurse that might be able to kind of review things with more experience. If someone is not opiate naive and you think, well, this person's dying and they're not going to manage their MST in the morning, they had it last night, but they're really not going to manage it in the morning, then that would be a good reason to start a syringe driver as well. And that's a relatively straightforward conversion. The oral dose is double what the subcut dose should be. So if they were on 10 milligrams, for example, of MST twice a day, then that's going to be 10 milligrams in a syringe driver. Remember that if patients are not opiate naive and they've been on bigger doses, or they've been on maybe a fentanyl patch, you can start a syringe driver in addition to whatever normal opiates they have on board, and we keep those going. So we've not mentioned fentanyl patches up to this point, and there's kind of a lot to cover, so I won't go into every drug. But what we do there is keep the patch on, replace it as normal, and then add in an appropriate syringe driver opiate on top of that. But just bear in mind that their PRN dose needs to be calculated from their total opiate, long-acting opiate. So you need to put that fentanyl into that calculation. And that's where you get your pen and your piece of paper and your quiet room, and you put your bleep down and you work it out, and then you get the nurse to check it with you, or you run it by the registrar on the phone.
Yeah, that's a really practical guide to the 2 a.m. does this person need a syringe driver? And I really like that approach of just trying PRNs and seeing the response to them. I think that's really sensible.
I think that can also be really helpful if you're going to phone palliative care. So most places will have a palliative care, either consultant or registrar on call, usually from home overnight. And they are happy to be phoned to talk through end-of-life medicines. But what they want to know is an assessment of that person's symptoms and response. So if you arrive at a situation which is clearly a distressed patient, the first thing you should do is give whatever PRN they've got prescribed straight away and see the response. And then that's going to help you when you pick up the phone in 20 minutes and say, look, I've given this dose of 15 milligrams of levomepromazine that I'm really not comfortable or familiar with, and it didn't do anything. Then that palliative care doctor can really help you and work out what to do, because you've got that information to give them about what's working and what isn't.
Yeah, absolutely. And it is individualized. So some things might work beautifully for one person and not have a response for the other. And I think people often get worried about sort of starting that 10 and 10 morphine and midazolam. That's quite common, isn't it? But sometimes feel a bit worried about starting that, and it feels like, am I going to really oversedate this person? And actually, when you rationalize it, that's less than 0.5 milligram an hour of morphine. And actually, the other thing that's helped me in the past is, like, what is your goal in this situation? And your goal is not for this person to be totally bright and alert, and your goal is actually symptom control, and you're chatting to the patient about what their goals are as well. And actually, we need to keep that goal really clearly in mind when we're giving symptom control in these situations.
Absolutely. And I know we said we'd focus on pain, but we're talking about syringe drivers in the final days of life. And actually, terminal delirium or terminal agitation is an incredibly common symptom. And the treatment for that is sedation. So the treatment for that is dealing with pain, but also using sedation appropriately. And in the kind of hypothetical example that we've used here, I don't think any of our listeners would be expecting that person to be alert or up or eating, drinking. That person is clearly dying, and starting relatively low doses of drugs and getting them in and then reviewing things later on is absolutely going to, help that person to have their symptoms controlled.
And then we're talking about reviewing syringe drivers. And I remember being an FY1 on call many years ago and having this on like my weekend jobs list, review the syringe driver, and thinking, how on earth do I do that, right? No one teaches you. And obviously I've had a lot more experience since then, but it might just be good to talk about the approach to actually just reviewing and adjusting once you've started that syringe driver on that person.
Sure. So it's a very common scenario, isn't it? So maybe the palliative care team have been involved all week and have been adjusting a syringe driver with all their wealth of knowledge and experience. And then you're the pretty junior person coming along, or even maybe not so junior person coming along on a Friday or on a Saturday and trying to review, comfort review. So the first thing to do is to recognize that you coming and seeing that patient for 5 minutes is a tiny bit of the assessment. Okay, so what we need to do is to gather some information. We need to speak to the nurses on the ward. We need to speak to ideally family that have been, if they have been spending time, and we need to get some kind of global sense of how things are. Are they fine all of the time? Are they really distressing, but then the PRNs are working? Are they having any time awake and undistressed? So these are some of the questions that I ask families and nurses. Okay, is your patient able to tell you anything? So they may be able to squeeze your hand. So I always ask patients, are you comfy? Because even patients right at the end of life can sometimes manage a yes or a no. I wouldn't, if I am only getting one word answers in that situation, ask them too much or exhaust them too much. But my question of are you comfortable is a helpful one, I think. And then I'd be looking at the drug chart of the electronic prescribing system and looking to see how many breakthroughs they've used. Now, if they've used several, as in 3, 4, 5, 6 upwards, then clearly that syringe driver needs to be increased. And a basic starting point would be to tot up what they've had PRN, add it up and add it into the syringe driver. And if that feels like a big jump, then reassure yourself by saying, but they've had that in the last 24 hours. So I'm not giving them any more. I'm just giving it in a more controlled and less up and down fashion. Okay. I wouldn't just use the PRNs as a basis for which I would base my assessment. So I would also want to look at the patient I would want to have some clues about whether they look comfortable. You know, this is really kind of clinical skills and clinical assessment at its, you know, there is no blood test to say if your patient is comfortable, but if they're grimacing, if they look like their neck is not fully resting on the pillow because they're rigid, you know, if they look uncomfortable, they probably are uncomfortable. So use those sort of softer examination skills to the best of your ability. And then I would say also, where are they? So are they in a place where you trust that the nurses have been able to also recognize that overnight? Do you trust the fact that they've only needed one dose of PRN overnight and therefore they were not distressed? Or do you think that that was woefully underdosed because it's a busy A&E department, they've been waiting for a bed for 16 hours and nobody's recognized or have time to give them medicine? In which case, you might say, well, they've only had one dose, but actually we still need to go up significantly. So you're using a global assessment. Ask for help. So phone your registrar, phone your consultant, phone the palliative care team, but have those points of information to discuss on the phone because that's what they'll want to know. So they'll want to know, as I say, what happens when you give a PRN dose. If you phoned up because it's just scary big numbers and you need to talk it through with somebody, that's absolutely fine. And reassess. I guess it's like anything, you know, it's like a fluid review. It's like a low sodium that you need to recheck. As long as you reassess, you can make a decision. Okay, you can make a decision and say, well, I'm going to check in 6 hours that this was the right decision to make.
Yeah, and that's the benefit of being in hospital medicine as opposed to being in the community, when there's a bit more sort of risk and uncertainty that you take on. And I guess that's where your goals become important as well, is actually if good symptom control is your goal, then you might need to just be a bit more.
Absolutely. And I think, you know, I occasionally sort of prescribe remotely syringe drivers. So on a patient I may not have met, but the hospital at home team have met. And what we're then trying to do is anticipate what's going to happen in the next 24 hours. That should be what we do in every patient. But if a district nurse has to come and she might be at the other end of West Lothian and there might be a 2-hour delay, then clearly that's going to influence the doses of drugs that you're going to think about putting in a syringe driver.
Yeah, and if that patient's dying, then the risk of undertreating is much higher than the risk of overtreating.
Exactly.
And I think so that's a really important point about speaking to the nurses, not just looking at the drug chart, because they might have had 6 doses of midazolam, but actually might have had no response to that midazolam. And therefore, that is not the right drug to put in the syringe driver because it's not helping. So has it helped or has it not helped is also, I think, key.
Exactly. And I think, again, that's where I would be speaking to families. So it might be scary if there are lots of family members in a room. And certainly it's okay to go in and say, could maybe 3 of you leave, but 1 person stay? I sometimes do that. And then speak to that family member because they know their loved one the best. And they will tell you if they think that they're sore or distressed or have been very settled. And they might need some reassurance from you, and you're not looking to put the burden on them of decision making, but it's really helpful. It's like taking a collateral history at that point.
Yeah, and I think in any situation, but particularly in end-of-life care, bringing the family into the multidisciplinary team can only be beneficial. They've got such a wealth of knowledge and insight, and their uncertainty and stress will be less by feeling like they're part of that care team. So that's always helpful to do. Okay, so we've covered a lot of ground, I think.
We have.
And we could talk about this forever because it's such a great topic, but we'll probably have to round off there. And I just wondered whether you have some take-home messages or top tips that you'd like the listeners to go away with.
Yeah, so I'd say don't undertreat symptoms at the end of life. Be aware that the elderly probably get undertreated, okay? And the most important thing you can do is recognize distress, and then there is always somebody to help you do the prescribing if you're stuck. If you've recognized that that patient needs something to change, then that's half the battle. So that would be what I would say about treatment there. I think it can be difficult to manage stressed families, but good, regular, honest communication can make a huge difference. And it can make a huge difference to their bereavement and their grieving process as well, if they feel that they've been, as you said, listened to and part of what is a unique and special time, albeit incredibly painful for most people. And my final take-home message is, when thinking about prognosis, have that graph in your head. Think, what line is my patient on? What 2 lines might my patient be on? And don't shy away from the question. And if you don't know, be honest. Say you don't know. Say you'll speak to somebody that can answer that question for them, or come back to them at a later date and say, you know, I've never thought about it. And do you still want to have that conversation about how long there is left?
Thanks so much. So important. And I think this is a really key part of medicine, actually, for anyone that's practicing it, is that we have a responsibility to ensure people have as good a death as possible. And that's about all of the things that we've been talking about. So thanks so much, Imogen, for coming on the podcast. And I hope that's been enjoyable for the listeners. I've certainly loved having this chat and hope to see you next time on Clinical Conversations.
The TNMC sister podcast, Career Conversations, supports medical students and trainees with career guidance and progression, as well as professional development. We wish to recommend our Demystifying PACES podcast series on career conversations. As some of you may know, in late 2023, MRCP UK updated the PACES exam format, so we developed this new series to support PACES candidates. Episodes cover exam organisation, calibration, every PACES station including key changes, and candidate perspectives.